Okay, have you started recording?
I clicked it. There we go.
It's not okay. Right, we're going to do this on antepartum bleeding. I added a little bit at the end on methods of delivery as well, because some of the feedback comments had been that people wanted that. So if we have time, we'll go over it. If we don't have to. But it's just like an SBA and a couple of slides, but most of that actually is on antepartum bleeding. So, preterm labour is the onset of labour before 37 weeks gestation, and it's counted between 24 and 37, and basically it's regular contractions resulting in opening of the cervix, and it can result in preterm birth. So there are different classifications. So just preterm is 34 to 37, very preterm is 28 to 33 plus 6, and extremely preterm is less than 28, and these babies are the ones that have the lowest chance usually of survival. So just something to note. Although I don't think most of the time people just say preterm, you don't generally see this classification, but just be mindful of it. So the causes of preterm labour. Does anyone want to hazard a guess in the chat, or you can put your mic on? We'll just go at the chat, people feel more comfortable, of the different causes. So I've linked them into iatrogenic and spontaneous. So can anyone come up with anything that will go into either of those categories? Any ideas?
This is a good way to split it. I hadn't thought of it like this.
Eclampsia. Annie, do you think that would be in iatrogenic or spontaneous? Okay, we'll go through them. So iatrogenic basically is planned delivery. So someone has been induced early due to a complication. So this includes things like eclampsia, eclampsia, preeclampsia, that kind of thing. If a baby is large for date, so for example, if you've got a mother with diabetes, then you might induce her early because the baby will continue to get bigger. And if it continues to get bigger, you're more likely to have complications by the time that she starts to labour naturally. So you might induce labour early. And they've got intrauterine growth restriction. So this kind of seems counterintuitive, but if the baby's not growing very well, you want to deliver the baby because it's going to continue not growing very well. And you basically want to get it out so that you can start offering support to the baby. And then multiple pregnancies. So twins are usually induced before birth before 37 weeks, and depending on the type of twin, some are induced as early as 32 weeks. So, for example, if they've got risk of twin-to-twin transfusion, so twins that share the same placenta and sac, you may induce as early as 32 weeks. And then spontaneous causes are things like uterine distension. So having twins or triplets, like multiple pregnancies, can cause you to go into labour early because the uterus is bigger than it normally would be, and therefore it just causes early labour. And then polyamhydrosis, which is excess fluid. And then if you have a uterine abnormality, some sort of congenital abnormality that a mother has that means that she's more likely to go into preterm labour. Then cervical weakness. So basically this is previous cervical surgery. So for example, like a Cohn's biopsy or one of those looped procedures, like the loop, I can't remember what it's called, but basically what you do for cervical cancer, that increases the risk of spontaneous labour. And then cervical trauma, or the cervix just being really short. So if it's naturally short, it increases the risk. And then maternal infection, so UTIs, and then, right, I don't know how you say this, but basically it is choroamniosis is an infection of the amniotic fluid, and that increases the risk of preterm labour because you stress out the baby and that kind of thing. And then antepartum hemorrhage, because thrombin that is released from the bleeding can stimulate the uterus to contract. So that is a weird one, but one to be aware of. Okay. We'll go. So this is Poppy. She is 26 years old, and she is 29 weeks pregnant. She has come into hospital thinking that she's having contractions. She's given birth previously, and the pain she's experiencing now is the same as before. Upon questioning, that she realises her water might have broken yesterday, although she didn't realise at the time. So, as well as preterm labour, what else is Poppy experiencing? And what is the most appropriate management for Poppy? Has anyone got any ideas? Just pop them in the chat. So anyone know she's got preterm labour? What else has she experienced? Yes, Annie. She's also got premature rupture of membranes. Yeah. So she's got preterm premature rupture of membranes. So we're going to come on to those in a second. And then appropriate management. Anyone know what that is? What that would be? There's quite a lot of it. So have a think and we're going to come on to it now. So the first thing that you want to do is discuss viability. So in this case, the baby is 29 weeks. So they have a chance of surviving with the right support. So you want to discuss viability and transfer to a neonatal unit. So some places can look after babies that are more premature than others. So I know like Barnet and the Free. I think Barnet has more premature babies. So when I was there were babies being rushed from the Free, or mothers being rushed from the Free to Barnet, because Barnet has the facility to take babies born like before 32 weeks. So you need to transfer someone there to the right centre, and then alert neonatologists so that they can get the right support they need. Then continuous CTG monitoring. So you want to look for signs of distress. If the baby's distressed, you might go ahead with instrumental delivery if you can, or go straight to a C-section. And then, so as Ania said, you want to give tulytics, which relax the uterine smooth muscle. So these are things like nifedipine, which is a calcium channel blocker. Sorry, my screen just went funny. A sorbitan, which is a oxytocin receptor agonist. Then you've got like beta agonists. Magnesium sulfate is not used in the UK as a tulytic, but it does have that property. It's used in the US as one. And then NSAIDs like NSAIDs. So then these basically delay labour, usually for 2 to 4 days, or sorry, 2 to 7 days, which gives time for steroids to work, and it also gives time for you to transfer the baby to the right facility for them. The next thing you give is steroids. So these are given if the baby is less than 34 weeks, because lung maturation occurs around 34, 35 weeks. So they stimulate lung maturation and surfactant production. So you basically need 2 or 4 doses depending on what you give. You give dexamethasone 2 doses 24 hours apart, or you give dexamethasone 6 doses 12 hours apart. But you need to make sure you have time to give all of those doses, and then they need 24 hours to work. So basically you need to allow like 2 days for the steroids to work effectively. And then you give magnesium sulfate, and this is for neuroprotection if the baby is less than 30 weeks gestation. And as I said before, it can also cause uterine relaxation. Does anyone know, in terms of neuroprotection, what does magnesium sulfate actually protect against? Anyone, any ideas? Oh my God. Okay. Cerebral palsy, so it protects against basically brain bleeds, which can protect against cerebral palsy. Another thing, so it protects against like intracranial hemorrhage that babies can get, when they're basically due to like birthing issues, and they are more common in premature babies. So the more premature the baby is, the more likely they have to get a brain bleed. So you can give them magnesium sulfate, and it reduces the chance of the brain bleed. And then you give antibiotics. So for PPROMs, you give it if they've been PPROMs. You give it if, oh my God, sorry. For PPROMs, you give it if they have been in if they've been like labouring for over 18 hours, you give oral erythromycin for 10 days. And then if they're GBS positive, you also give IV benpen. But if they're not PPROMs, if they're just PROMs, then you give it if they've been in labour for 24 hours, and you just give IV benpen straight off. Does that make sense?
I think that's quite an important distinction, right? With the PPROM versus just PROM as well. That's something they like asking about generally.
So someone said, Annie said, what is, okay, so it is group B strep. Annie, GBS is group B strep. So it is the most common cause of neonatal like sepsis and meningitis within like the first 24 hours of birth, and it's usually obtained by the baby from the birth canal. So like lots of women carry it asymptomatically, so they don't usually screen for it, but it is the most common cause of sepsis and meningitis, and that can obviously cause issues for the baby. Does that make sense? Okay, rupture of membranes. So there are two different types. The first one is premature rupture of membranes, which is basically the spontaneous rupture of membranes 1 hour prior to the onset of labour at greater than 37 weeks gestation. And the other one is PPROMs, which is spontaneous rupture of membranes more than 1 hour prior to the onset of labour at less than 37 weeks gestation. So Our Lady had experienced PPROMs because she was only 29 weeks. So she'd had premature rupture of membranes at less than 37 weeks gestation. So some of the things to note about premature rupture of membranes is that basically it's caused by like a physiological weakening of the membrane. So like an enzymatic breakdown. Sometimes Braxton Hicks contractions can cause it, but also you can get it from like cervical ripening early. Risk factors include previously having early rupture of membranes and antepartum bleeding, and then also things like infection can increase the risk, so UTIs and genital infections. Then smoking, so invasive procedures. Can anyone think of an invasive procedure that you have which might cause premature rupture of membranes? Oh my god. Right, Anoush, my screen has gone really like peculiar.
What does it look like?
It's basically like frozen, like I can change the PowerPoint, but I can't scroll or anything on the comments.
I'll read them out. Amniocentesis?
Yes, that is the one I was thinking of. I might have to leave and come back in a second. So amniocentesis can cause premature rupture of membranes. Also things like trauma can, and then polyamhydrosis and multiple pregnancies, as well as causing preterm labour, can also cause the membranes to rupture early because the membranes are all stretched. So the management, if there's clear liquor and the mother is not group B strep positive, you usually just do expectant management. So you just wait basically, and most women will go into labour. And then after 24 hours, you can start to augment labour. So you can give like prostaglandins and infusions of oxytocin and that kind of thing. And basically, you just monitor signs of infection of the amniotic fluid. So that chorioamniocentesis thing I was talking about earlier. So you just look at their temperature, you monitor the CCG and that kind of thing. If they've got meconium in the fluid, that's so in the their water, or if they're known group B strep positive, or if the mother's got fever, then you induce labour straight away. Does that make sense? And in preterm premature rupture of membrane, most women will go into labour, and there's little you can do to stop this. You just want to try and do those things we talked about earlier. So you want to try and do these things to try and help, if anything, like stop the labour if you can, and to make sure the baby's as ready as possible. Does that make sense?
Out of interest, Jess, have you seen atosaban being used at all?
No, the ones I saw were calcium channel blockers.
Yeah, I think it's quite like a tertiary thing, right? It's quite an expensive drug. Yeah, sorry, just curious.
Anoush, can you quickly take over the screen so I can leave and come back?
Sure.
Everyone read the slide. Sorry, I don't know why it's going funny.
Sally, a 24-year-old woman, has come in with vaginal bleeding. She's currently 35 weeks pregnant and is worried there could be something wrong with her baby. What are the possible causes of her bleeding? Okay, go on, guys. You can do this. Even I can do this while Jess returns.
Okay, I'm back.
Oh, that was quick.
Yeah, the screen. Oh no, it's gone funny again. Right, I'm leaving again. Bear with me. Sorry.
So go on. Tell me what the causes of bleeding in. Oh, you took control, so the slides are gone. Well, she comes back. Yeah, what are the causes of early bleeding in pregnancy? So yeah, things like abruption, things like placenta praevia. The Vasa praevia less so, but could definitely still be. Yeah. So let's. While Jess returns, let's talk briefly about what these are. So Valeria, can you tell me what placenta praevia is?
No, Anoush. Oh, right, hold on. Okay, it's loading.
Oh, she's back. It's fine.
Okay, basically, I can't click on the chat function. If ever I click on the chat function, the screen goes funny. So keep writing in the chat, and Anoush will read them out. I'm really sorry that it's going mad.
Cervical atropion, also very important, because remember that just because it's bleeding during pregnancy doesn't mean it's associated with the pregnancy. It could be things like usual gynecological causes as well. Yeah.
Okay.
Anything else you can think of? You've got the main ones, to be fair. Go on, Jess.
So you've gone through, Anoush has already gone through these with you. So what are the causes of antepartum bleeding? the main ones we're going to discuss are placenta praevia, Vasa praevia, placental abruption, and then non-pregnancy things, as Anish said, are really important to consider. So like ectropion, polyps, and cancer, because they can still happen in pregnancy. Obviously, they're not as common and they're rare to occur, but they can still happen. So you need to bear those in mind, because there's no point investigating for all these other things like placenta praevia and Vasa praevia if actually when you check the woman's got an ectropion that you've just missed and everyone's gone looking for some placental abruption that's not there. So the first thing we're going to discuss is placenta praevia. Does anyone want to explain what this is? Or hazard a guess what this is?
They love this in obs and gynae. I got so much teaching on this on catch-up.
Tina. Yes, so this is basically abnormal attachment of the placenta. No, not abnormal attachment of the placenta. It is when the placenta overlies the cervical os, and it can be linked to abnormal attachment of the placenta, Tina, but it is not abnormal attachment. We'll come on to what abnormal attachment is later. So basically, it is when the placenta is abnormally attached to the lower uterine segment, so it covers part of the cervical os, which is obviously problematic because the baby comes out of the cervical os. So risk factors are uterine scarring, because the placenta can adhere abnormally to the uterine lining, which would be, so they're linked. So you can get placenta praevia with like abnormal, when you have like placenta accreta and then the other placenta, other ones where you can implant even further. They're often linked together. So you might have placenta praevia because the mother has placenta accreta and the uterus is has got scarring in it, so the placenta is attached in a weird position. That means it's covering the cervical os. So it's not the abnormal adherence, it's the fact that it's covering the cervical os. So it can be caused by having many babies, just means that the placenta implants in funnier places, and then multiple pregnancies, because if you have multiple pregnancies, the babies take up more room, and it might mean that there's less places for the babies to go, and earlier on they're higher up, so they're not covering the os, so it might mean it's easier for the placenta to implant at the os. So there are 4 main types, as you can see from the little diagram I've got there. Does anyone want to, there are 2 broader categories. Does anyone know what they are? Which these 4 different categories go into? No. Anush, why is this happening? I don't know.
Can you upload them again, sorry?
I'm doing it again. I'm sorry, everyone. The computer system is not having a good day
Teams,
today.
to be fair, Teams has been having issues over the weekend because
maybe I'm going to blame that as being why.
Yeah, great. Yeah, you can do minor, major. You can
minor
do the grading.
and major. So when we get back to the slide, I'm sorry, everyone. Okay, so there's major, which is complete, which is basically, as you can see in the diagram, it's the far right photo. It's basically when the placenta isn't covering the entire os, so it's completely covering it. And then you get partial, which is where only a portion of the placenta is covered. It's covering the os, sorry. So only a proportion of the os is covered. And these are the 2 like more serious ones, because they're less likely to resolve as the pregnancy continues. Then you can get minor, which is marginal. So basically that is when the edge of the placenta lies within 2 centimetres of the os. And then you get low-lying placenta, which is when the edge of the placenta is within 2 to 3.5 centimetres. So in minor and major, it's not covering the os, but it's very, very close to the os. So basically minor, it may resolve during the pregnancy, because during the pregnancy, the placenta basically moves upwards as the pregnancy progresses, because the lower segment of the uterus forms in the 3rd trimester. So basically what happens is you have your like uterus and the placenta is here, and the placenta basically moves up because the uterus grows upwards and the lower part forms later on. So in low-lying and marginal, it's likely that the placenta will be moved further away from the os, and therefore it's not a problem. And in some cases, partial can resolve because it's only half covered. So if the placenta like moves up enough because the uterus like grows enough, it will resolve. But complete is not going to resolve. So low-lying and marginal probably will. Partial could, but it's not very common, and complete definitely will not. So they are just like important things to note. Is the ones you want to worry about are complete and partial.
Just correct me if I'm wrong. So the grade 1 to 4 somewhat correlate with these, but they don't really use them clinically so much anymore, right?
I don't think so, no.
Yeah,
Normally
yes.
they use this system because it describes it better.
Yeah, so yeah.
In terms of like how to...
Good to be aware of the grades, but yeah, they're probably not going to ask you about that in exams. It's, yeah.
So, okay, we'll do this in a second. So basically, the symptoms. Anyone want to guess the symptoms you get?
Spoilers, you just saw them, but guess anyway.
Any ideas? Okay, so the main ones that you get are painless, bright red vaginal bleeding. So, and it can range from spotting to hemorrhage. So some women will get like spotting, and just get several episodes of spotting, but bright red spotting, and some women will get like full-on hemorrhaging. It just varies, and it can depend on the grade. So you're more likely to get hemorrhage with complete placenta praevia than you are with like low-lying. And the fact placenta praevia is like important because it increases the risk of hemorrhage. And it's possibly due to like a defective attachment in the uterine wall, or it can be due to the damage from the fetus as it moves down. The fetus can like damage the placenta and then cause bleeding. And the bleeding is from the maternal circulation, so you have to get a lot of bleeding to cause maternal compromise, which is important to note because as we go on, some of these conditions affect the mother and some affect the baby, like some cause maternal bleeding and some cause fetal bleeding. And the ones that cause fetal bleeding, the fetus only has a small amount of blood, so if the fetus loses some blood, it'll have a detrimental effect, whereas mothers can lose a lot more blood before they have an effect. Does that make sense? The other things are soft uterus. You'll see why this is relevant later on because it helps rule out differential for another condition. And the fetal head is high on abdo exam. Can anyone guess why the fetal head is high? So like a mother might get to 39 weeks, 40 weeks, and the fetal head is still high. Why is that? Any ideas? Basically, it's because the baby can't engage because the placenta is blocking the os. The baby can't descend down, and his head can't engage because it's got nowhere. It's physically got nowhere to go. So investigations, you do an abdo ultrasound, which basically may show abnormal position of the placenta. So you might be able to see it on the 20-week abnormally scan. Yes, Vikram, sorry, I didn't see you. Yeah, it's because the placenta is low that the head can't descend. So sometimes on the 20-week anomaly scan, you can see the abnormal placental position, but often you can't find it. But if you do see it, what you would then do then is a transvaginal ultrasound because it will help you evaluate how much of the os is covered by the placenta. And this will help you categorize better if it's like complete, marginal, partial, blah, blah. Does that make sense? So
there's a quick question. Are you able to do speculums or bimanual examinations in these patients?
Okay, so you shouldn't do bimanuals in any of these patients, but you can do speculums. So you can do a speculum because all you're doing is inserting the speculum and looking at the os. Bimanuals, you're like feeling around, so you shouldn't do a bimanual, but you can do a speculum. That's a very important question. So the thing you should never do, if someone's got antepartum bleeding, you should never do a bimanual, but you can do speculums because everything's sterile and you're just putting it in and taking it out again. Okay, so the management. So if it's identified at 20 weeks on the scan, you basically do pelvic rest, so the woman's not allowed any penetrative sex or anything like that because that can increase the risk of bleeding. You then rescan them at 32 weeks because by this point you're hoping the placenta's moved because the placenta should have ascended upwards as the third part of the uterus forms. If it's not moved, you rescan again at 36 weeks. If it's still not moved, you follow the pathway I'm going to show you in a minute, which is for like a confirmed placenta praevia. But if it has moved, then you can just continue as a normal pregnancy and the woman can labour as normal and can have a vaginal delivery. However, if you've confirmed that the woman has placenta praevia and they're asymptomatic, so they've had no bleeding, but like it was found at the 20-week scan and that the 36-week scan is still there, then you want to plan for delivery. So you'd give these women steroids if they're less than 34 weeks gestation, and then if it's major, so if that means if it's partial or complete, you would do a C-section at 37 weeks. So you do the C-section at 37 weeks because you want to do it before the woman goes into labour. So by doing it here at this time frame, you're hoping you'll catch her before she goes into labour. If it's minor, you can wait for vaginal delivery if the head is engaged. If the head is not engaged below the placenta, then you'll do a C-section. But if the head is now below the placenta, you know it's fine and it's going to be engaged and the baby will be born fine. If there is persistent minor bleeding, you can admit and prepare for delivery as above. So if it's minor, then you can still do a vaginal delivery. If it's major, you'll just do a C-section. But if she's got major bleeding, you'll do a C-section regardless of what grading she has. Does that make sense for everyone?
I feel like this is something that comes up in exams quite a bit as well. Just worth pointing out.
Hopefully, I think you'll get the slides, but I'm hoping this diagram clearly lays out the different pathways you follow.
Yeah, as long as you have a rough idea of what you're doing, you'll be fine.
Okay, the next one is Vasa praevia. So this is when the fetal blood vessels are uncovered by the membrane. Fetal blood vessels are uncovered by membranes and they lie below the placenting part of the fetus and they overlie the cervical os. So basically what happens is, I've got a diagram on the next page, which hopefully should show you a bit better. Basically what happens is the fetal vessels lie underneath. Here's the fetus and the vessels lie underneath the fetus like this. So if the fetus is going to be born, it's going to go onto the vessels. And the vessels are not protected, so they're at high risk of tearing when the membranes rupture and the cervix dilates. And this will cause massive compromise for the fetus because it's the bleeding is fetal bleeding because it's the fetal blood vessels that are rupturing. And that's obviously bad because the fetus has a small amount of blood. So as I said earlier, the fetal compromise and fetal bleeding is really bad because the fetus only has a small amount of blood to lose. Does that make sense to you all?
And also, this is actually really rare, right? But it's really important to recognize it, is what I was told.
It is really rare. I think there was an episode of it. I didn't see it, but there was when I was at the Free, there was a lady that had it. So basically, the risk factors for this are when an abnormal placenta, because it increases the risk of, and we'll come on to why in a normal placenta in a second, having placenta praevia, so having what we said a minute ago, if you've got a low-lying placenta, it's likely that the vessels are going to be in a weird position as well. So this Vasa praevia can go hand in hand with placenta praevia. And then multiple gestations. Like I said before, with the placenta, if there are more babies, it's likely that the placenta will be in a weird place and then all the vessels and everything will also be in a funny place. So there are two different types, as you can see on this diagram. So the first type is type 1. This is a velamitous, I have no idea how you say that, but just roll with it, insertion with exposure of the vessels running over the cervix to a single placenta. So basically, you can see the baby, and rather than the vessels just going across to the placenta, they're literally going all the way underneath its head and up to the placenta. So the baby is going to hit those vessels when it's born. So usually they just go across the body of the baby rather than under the baby. And normally they go into the middle of the placenta. If you look here, they're going into one of the ends of the placenta, which increases the chance of them going a weird route. But normally the placenta, the vessels, come off the middle of the placenta. They're right off the middle and they just normally go across the body of the baby into the belly button. And then the second option is basically when the fetal vessels run between two lobes of the placenta. So sometimes you can have a placenta with two lobes. It's not very common. Or you can have a multi-lobated placenta where they're attached with a really thin bit and then there's another lobe. And basically, so you have more than one accessory lobes or a bilobulated placenta. And so the first vessel running into the placenta is fine, but then the links between the two placentas is the problem. Does that make sense?
Just to answer the question in the chat. So yeah, the fetal blood vessels are included in the placenta. So Vasa praevia is where, so from the placenta, the blood needs to get to the fetus, and it's just that connection in particular that is at risk in Vasa praevia.
So like it's from the umbilical cord that comes out the umbilical cord and then goes round. And there are fecal vessels in the placenta, but the vessels that go from that's how the vessels, as Anu said, attach to the baby. They go via this like cord to the baby.
Yeah.
And part of it is covered, but part of it is not covered.
Yeah. And in Vasa praevia, there's a longer portion that's uncovered and at risk of tearing, because it's taking such like a convoluted route a person just moved across, as Jess said.
Annie, does that make sense?
Yeah. Hopefully the image helps a bit. But yeah, let us know if it's not clear. Fab.
If it doesn't, I can explain it again. So there are three like main symptoms of this. This is a triad. Learn the triad because it makes SVAs way easier, and also for like real life, if you ever do obs and gynae, it makes it much easier. You get painless. Important is painless because it's not from the mother, it's from the baby. Fresh vaginal bleeding. Upon rupture of membranes, so when you rupture the membranes, you get the painless bleeding, and then you get fetal distress. So on the CTG, you might have like decelerations, there'll be a heart rate less than 120, and you'll get this synovial trace, which is like that, like basically like a sine wave trace. You can get it, not always, but it's those like signs are worrying, and along with the two other, like the rupture of membranes and the bleeding, you're really concerned about Vasa praevia. So then investigations, usually you don't do anything, it's just a clinical suspicion. So if the mother's started bleeding upon rupturing her membranes and the CTG looks bad, then you're suspecting Vasa praevia. So you can detect it at 20 weeks on the anomaly ultrasound, like if the scan looks funny, so the placenta's in a weird place, or like the placenta's bilobulated, you might suspect it then, but it's more difficult to pick up. And usually it's one of the things that generally presents at birth, which with these like clinical symptoms. So the last thing, management. So if you detect it early, so for example on that anomaly scan, then you can do you can admit the woman from 30 weeks in case she ruptures her membranes, because obviously if she ruptures her membranes, then the fetus is like not going to be happy, and you're going to put them under a lot of pressure. So you try and admit them so that if membranes are ruptured, you can rush them straight for a C-section. You give them corticosteroids to help with lung maturation, because it's likely that the baby will be delivered early, because you will be delivering them by an elective C-section around 36 weeks before like you give the membranes a chance to rupture. Yeah, so management, if they're bleeding, you follow the ABCD protocol and you just rush them straight for an immediate C-section. Does that make sense?
Immediate C-section is like the answer to half of the like antepartum emergencies, just a heads up. So if you've forgotten in an exam, that's probably the definitive management.
Okay, and the last of the antepartum hemorrhages is placental abruption. Has anyone got any idea what this is?
The one to not miss is this one.
And this is slightly hard to like identify clinically.
But good thing they make it pretty obvious in SBAs. Yeah.
So basically, yes, victim separation of the placenta from the uterine wall. Yeah, because you know it's early detachment, and it doesn't have to be early, but it's detachment, and it's tearing away from the placenta from the uterine wall. Although I guess it is early in the sense that it caused before birth. So yeah, you're all right. So correct answers, guys. So basically, what happens is the placenta basically bleeds into the bed of into the bed of the bed which attaches it to the uterus, and this causes it to separate from the uterine wall before delivery of the fetus. And then what happens is more blood accumulates. As the blood accumulates, it causes more of the placenta to detach. So it's like a vicious cycle. Like you get a little bit of bleeding, a little bit of the placenta disattaches, and then as it keeps bleeding, more of the placenta disattaches, and then more can disattach. And the bleeding is mainly maternal, but it can be a little bit fetal, so it can have consequences for the fetus in the sense that they are losing blood too, but it's mostly maternal blood because it's from the bed of the placenta rather than the actual placenta itself. Yeah, so basically what happens is you get bleeding, into the basal layer of the endometrium, which causes the placenta to detach away. And it usually happens in the 3rd trimester, but it can happen in the 2nd trimester. So it's around the 2nd to 3rd, but usually in the 3rd trimester. And the vessels rupture due to trauma. So the woman might have fallen over, she could have an abusive partner, that kind of thing. Vasospasm, so cocaine use. This is a rogue SBA question, but you might get an SBA saying she did cocaine yesterday. Then you want to think about placental abruption. Smoking can also cause it. So women who smoke are at higher risk of placental abruption. And then especially smoking in pregnancy. So if they stop smoking, they're not so much at risk. It's more for continuing to smoke while you're pregnant. So hypertension and preeclampsia, because they can cause vasospasm as well and just put more pressure on the vessels. Polyonhydrosis and having had multiple children. So basically there are 2 different types. There is revealed and concealed, as you can see from this diagram I've got. So revealed, basically, it's when the blood drains through the cervix, so you actually have vaginal bleeding. So there's the blood kind of breaks, the placenta breaks off and you get bleeding, but it can leave the cervix. And then concealed is when the blood remains in the uterus behind the placenta, and you get this like retroplacental hematoma. Now this makes it more difficult to identify because the woman might have lost a lot of blood, but she actually hasn't lost the blood because it's still within the uterus. So these women can appear really unwell, but you can't work out why, because they've not actually bled that much. And it's because the blood's all collecting behind the placenta. And also it can involve the whole placenta, which is total placental abruption, or part of the placenta. And the detached portion is like it dies, basically. So the attached portion of the placenta dies, so it's unable to function. So if like a large portion of the placenta comes off, then you can have fetal compromise because that bit of the placenta can no longer function. So that's one of the reasons it's more dangerous for the fetus, is because if it's like a little abruption, then it's more so probably okay because the baby has enough of the placenta to rely on. If it's a lot of the placenta, they're going to have issues for the fetus. Does that make sense to everyone? I'm going to go with yes. So the symptoms of this, anyone want to hazard a guess? The uterus has a specific characteristic. Does anyone know what that characteristic is?
They really like the buzzwords for this. So if you've done any pass med, you know the drill.
Yes, because the uterus is hard. It's a woody uterus. I don't know, it's a bit rogue. I mean, I've never felt a woody uterus, but so what happens is if it's a small amount of bleeding, if it's mild, you'll get like a small amount of bleeding, you'll get some pain. If it's major, so there's a lot of bleeding, you then can get like sudden onset severe constant abdominal pain. This is what makes placental abruption different to the other 2 conditions, is that it's painful, whereas in Vasa praevia and Placenta praevia, they're both painless bleeding, whereas placental abruption is painful bleeding. So that's like the one main differentiation, or one of the main differentiations, is that in placental abruption, the woman experiences pain. So it's not like a contraction either. The pain is constant and is severe, whereas contractions come and go. In placental abruption, they will describe constant pain. Then you then get this like tender, rigid, woody uterus. And the uterus is basically like really firm. And that is just basically from the bleeding that's happened. The uterus is now like all tensed up. You then get fetal distress, and often you get decreased movements, and that's due to some of the placenta disattaching and the fetus like having less supply from the placenta. And then you get maternal shock. So in revealed, this will be out of proportion with the blood loss. So the woman may have like severe tachycardia, she may look really pale, low blood pressure, but you've only identified a small amount of blood loss. That's when you're worried about like a concealed placenta abruption, because she's obviously lost more blood, but it's still within the uterus. And if it is revealed, you'll get a dark bleeding. It tends to be much darker than the blood that you get in Vasa praevia and Placenta praevia, which is much brighter. But that's like a minor differentiation point. So investigations, generally it's a clinical diagnosis as well. So it's based on history and examination. And then the ultrasound may show, so you can do an ultrasound and it may show retroplacental hematoma and increased placental thickening, which kind of suggests that there's bleeding behind it. However, they're not very accurate, so you might miss it basically. So it might not be on you might not be able to see anything on the ultrasound, but usually it's like a clinical diagnosis based on these kind of symptoms you get. Does that make sense to everyone? So the management, basically it depends on the maternal and the fetal condition. So if they're both stable and the woman is over 34 weeks and they're contracting but also bleeding, then you will do a vaginal delivery. So you may need to induce the labour, so you may need to give her like oxytocin and rupture her membranes artificially, but you'll induce labour. If they're less than 34 weeks, you'll do a regular ultrasound to try and look for any bleeding behind the placenta. You'll monitor the CTG, because if it gets worrying, then you'll do a C-section, and you'll give steroids to try and help lung maturation. And if the woman is less than 34 weeks, you will also try and consider giving tolytics to try and delay labour until at least she's over 34 weeks, if you can. Unless the baby's really distressed, in which case you'll go to the fetal distressed or mother unstable category, in which case you will just do a C-section straight away. And fetal death, so it's uncommon, but it is possible that you can get fetal death if there's like total placental abruption. If the mother's stable, you'll just birth the baby vaginally. If they're unstable, you'll do an emergency C-section. So has anyone got any questions on that before we go to the SBA? This just reminded me, as I said a minute ago, in Vasa praevia, this is the reason you don't do a bimanual, because you could touch the vessels and the vessels then like spasm and that kind of thing, so they can't be exposed basically, so you can't touch them, which is why you don't do a bimanual. It's fine to do a speculum because nothing's really touching them, but if you do a bimanual and you like go through the cervix, then you're putting the vessels at risk. Does that make sense? That's why you don't do the bimanual. So in any of these cases of suspected bleeding, speculums are fine, but no-nos are bimanuals. Okay, so this is Sally. I think we already had Sally, but Sally again. So she's come in with vaginal bleeding. She's currently 33 weeks pregnant, and is worried that something could be wrong with her baby, as she's not felt her baby move much since the bleeding started. She's had an uncomplicated pregnancy so far, but has moved to a new area, so did not have an anomaly scan. What is the most likely diagnosis?
Coming up with names is hard, to be honest.
I always have to pick the names of people I don't know as well. Oh. Anuj, can you take control quickly?
You've revealed the answer.
Yeah, can you? My screen's just gone funny again.
Great.
Can you take control?
Yeah, what are the answers, guys? What do you think? There's only one, so we haven't set up the Menti, sorry. Also, we've been kind of busy, sorry. But yeah, let us know what you think the answer is. Well, Jess fixes her computer again.
Right, I'm back. I'm really sorry, I've got no idea why this is happening. It's actually quite annoying.
Placenta praevia.
Any other ideas, anyone?
Vasa praevia. Anyone else? Okay. What do other people think? Let's see what other people think. Commit to something. It doesn't matter if you're wrong. Now is the time to be wrong. Ooh, another Vasa praevia.
Should have done a Menti.
It's fine.
Although they are incredibly hard to make, in my opinion. Okay, so the answer is Vasa praevia. So the things that are concerning in this are vaginal bleeding. She's not felt the baby move much, so they've got decreased movements since that she started bleeding. So if you go to the little summary slide, when you have Vasa praevia, you can have painless bleeding. So she didn't mention anything about pain, which kind of rules out abruption. She'd had and she has fetal distress, so it doesn't mention anything about rupture of membranes. But you don't tend to get fetal distress in placenta praevia because it's maternal compromise, not fetal. So the fact that she's got fetal compromise indicates that it's Vasa praevia. Does that make sense to everyone? And this little summary slide are the most important things to know about. Generally, the separation of Vasa praevia, placenta praevia, and placental abruption is on the symptoms. They're all generally clinical diagnoses. So that these are the kind of things you need to learn. Does that make sense?
Does fetal...
Yes. No fetal movement. If the fetus has stopped moving, that's worrying. So, for example, women are told to come into A&E or to go to like the antenatal unit, the prenatal units, if they experience like no fetal movement for over a day, because it's a concerning sign. The answer was Vasa praevia, because the answer is Vasa praevia because she's had vaginal bleeding and not felt the baby move, but she's not in any pain. So she's had painless vaginal bleeding along with the rupture of membranes, and the fetus is distressed. So no movement indicates signs of fetal distress. So you'll get women coming in to have CTG traces done when they've not felt the baby move for a day, for example. They'll be coming in. So that's something to look out for. So once the baby starts moving, they shouldn't stop. The maximum you want them to stop for is about 40 minutes, because that's how long babies in the womb sleep for. Any longer than that, you're kind of worried. Does that make sense? Pauline, does the answer make sense?
So basically, if there's no distress in either the mother or the baby, it's placenta praevia. If there's baby distress, it's Vasa praevia. If the mother is distressed, it's abruption, is the way I like to think about it.
Does that make sense?
Maternal distress is putting it lightly for abruption. I don't think distress is the right word.
So, as I said, the main things you want to learn about for antepartum hemorrhage are these symptoms, because that is what will help you differentiate in an SBA and also in real life between the different categories, because generally they're all clinical diagnoses. Okay, do you guys want to quickly go on to the SBA on mode of delivery? That is spelt wrong, sorry.
What mood are you going to set for the delivery? God.
My boyfriend spell checks these, but clearly I need to fire him and hire someone else. Okay, so basically Lily is 38 weeks pregnant. She went into labour 8 hours ago. She's fully dilated and has been pushing for 1 hour unsuccessfully and is beginning to get tired. The baby is engaged, but their head is malpositioned, so they're OP rather than OA. If you don't know what that means, we'll come on to it in another lecture. Just take from this that the baby is malpositioned. And the CTG trace is normal. So have a guess, people, in the comments. What do you think the most appropriate delivery method is? And then we're going to go through the options, hopefully, in the next 10 minutes.
What do you think of that? I have a fun story about this. So like last year I missed obs and gynae and I didn't have a clue about modes of delivery. So I messaged Jess being like, oh, is this like, I'm going to tell you what I understand and you can correct me. And what I said was so wrong that she just rang me and like taught me it in like 40 minutes because I just didn't have a clue what was going on.
In the question Anish did, there was this baby who was like, decelerating with a really worrying CTD trace. And Anish was like, continuous normal. Like, Anish, you're going to kill the baby.
Yeah, God. Okay. What do you guys
anyone
think?
Got any ideas?
Yeah.
It's kind of a hard question if you don't know. Sorry. I thought it was the best way to like go over the different options though.
That's not a problem. If you know the answer to this at this stage of the year, I'd say you're doing very well.
Yeah, I just kind of wanted to make a question that we could go over the different options for, so I came up with this one. Interesting idea, but no, Christina, you can't. You don't really. Well, we'll come on to why in a second. Okay, so the right answer is Keelan forceps. So she's beginning to get tired. This is important because in this situation, the CTG trace is normal, so you're unlikely to do a C-section. So that rules out 4 and 5. There's no point doing a C-section unless you really have to, because it has implications on the mother and for also future births. So if the trace is normal, you don't really want to bother with that. Now, she's beginning to get tired. Ventouse requires maternal effort. Forceps don't require maternal effort. That's the first thing. Ventouse you can do rotational deliveries with, so you can like turn the head as you do it, but it's much more complicated and people generally don't like to do it. Forceps, you can rotate them. Keelan forceps are special forceps used to rotate the baby's head as they are born. Whereas Neville Barnes forceps, and there are 2 other types which we'll come on to in a second, are just used in normal OA deliveries. Okay, that was a brief summary. So instrumental deliveries are when you deliver the baby vaginally with the aid of an instrument. So this is usually forceps or a ventouse. And you need to ensure adequate pain relief. So these women ideally need epidurals. However, often there's not time to do an epidural, so you might do a regional nerve block. If you're feeling barbaric, then you will do it with no pain relief, and the woman will probably hate you. I have seen it once because the baby was in distress, but the head was too low for them to do a C-section, and the mother was like, "It's fine." Like, she knew what she'd let herself in for, and they consented her properly to it. But you will have to have pain relief. An episiotomy is often needed, particularly with forceps, because they're likely to tear. You can, most people will do a episiotomy whenever you do an instrumental delivery. So most obstetricians will do it with forceps or and with the kiwi or a ventouse, but you really have to make sure you do it with a forceps because the likelihood of tearing is quite high. And then the delivery must be within 3 contractions. So every time the woman contracts, you pull on the kiwi or the forceps, and each contraction/pull counts as 1. So you have to do it within 3. If it doesn't work, then, so if you started with a kiwi, some people will go and try 3 with a kiwi and 3 with a forceps and then C-section. Otherwise, some people would just do 3 with one method and go straight to C-section. On the kiwi, if you put it on the head and pull and it comes off, that counts as 1. So important to note. And basically after this, so after 3 contractions or 3 pulls, or if the fetal head doesn't move down on one of the contractions, you need to abandon it and go to a C-section because it's unlikely to work. So the 2 different methods are the kiwi, which is also the ventouse. I think the kiwi is the brand of it, and then the forceps. So the kiwi, basically it's a cup that attaches to the fetal head via a vacuum. So if you look at this little photo, if you see this, you can see the yellow bit is the bit that sticks to the baby's head. And then the other bit is like a handheld squeezy thing, and you squeeze it basically to make a vacuum. I'm sorry, I realise my powers of description are terrible, but you get the idea. So it attaches to the head, and basically you apply a traction force during the contraction, so you pull downwards basically on it. So it can be used for direct and rotational deliveries. However, most people will probably not do it for rotational delivery. They prefer to use forceps because it's much harder to rotate the baby because you're trying to pull it and rotate at the same time, and it's really difficult. But it's important to know that you need good contractions and maternal effort. So if the mother's been going for an hour and a half and she's really tired, there's no point trying a kiwi because she's not going to be able to put in the effort you need. And that's why on this question we just did, it was wrong. So forceps. Basically, the blade is introduced into the pelvis, and the curve of the blade is applied around the sides of the baby's head, and then you lock them together. So as you look on this photo, you can see the bit where the 2 handles are locked together. It's important you lock them. They're locked together, and then basically you apply contraction force during the contractions, and this stretches the birth canal. So it doesn't yank the baby's head, which is what it looks like it does. It stretches the birth canal so that the baby's head can fit through, if that makes sense. But it causes maternal complications. So it causes lots of maternal pain, which is why you need pain relief, because you're stretching the inside of the mum's vagina. And it can cause maternal complications because you can get trauma. You can also get tearing and that kind of thing, which is why they advise you do an episiotomy with it. So there are different types. So there are Rhodes, Neville Barnes, and Simpsons, which are all used for OA deliveries. So when the baby's head is in the right position. Then there are Keelings, which are used for rotational deliveries. So if the baby is OP or OT, so with these ones you can put them in and spin the baby as you pull them out. This allows for you to do a vaginal delivery rather than doing a C-section. And then there are Wriggler's forceps, which are the ones used in C-sections. So I did not know this, but I actually saw it in one of the C-sections I saw. Sometimes if you have a really big baby, you actually use forceps to get the head out rather than just yanking. You can use forceps to help stretch the incision you made. So these don't need pushing to aid them because you're stretching the birth canal. When the mother contracts, and to see the contractions, you look at the CTG because these women are all hooked up to CTGs, and you look at it, and when you see them contracting, you basically pull on the forceps, it stretches the birth canal, and the baby comes out. So you don't need good maternal effort, so they don't need to push for this. Whereas with the kiwi, you want the woman to push. With this one, you just literally pull out as they're contracting. Does that make sense? It's quite a lot of information. Sorry.
Yeah, like I was going to say, just go over this. And also, Jess, you're doing like mechanisms of labor stuff in a few weeks, right? Which also kind of ties in with this. Like you have a labor
Yes.
talk. Yeah, so like it'll make a bit more sense when we synthesize everything together.
And then like indications for this is basically when the woman like lack of progress in their second stage. So she's not if she's a first time mum and she's been going for 2 hours, then you'll consider doing an intermental delivery. If she's a mum like a second time or third time or whatever mum, then it's after 1 hour. And then if you have suspected fetal compromise, so if you've got like an abnormal CTG or meconium or maternal fever or something like that, then rather than doing a C-section, you can try this and then go to a C-section. So say the baby's like descended and you can see the baby, like the head, then you might try this rather than going to a C-section because it would save the whole trauma of a C-section. Contraindications to this are an incompletely dilated cervix. You cannot put any of these in unless the cervix is dilated. Unengaged head, so if the fetus is too high, you can't put it in. If their baby is breached, obviously. If they have potential fractures, so if they have, what's the condition called? Osteogenesis like imperfecta? That one where they've got like brittle bone disease. You can't put it in because you're at risk of causing trauma to the fetal bones. And then for a ventouse, you can't do it if they have a face presentation, which is basically when the fetal face is the first thing that's going to be born because you can't stick a suction cup onto the actual face. If they're preterm, you can't do it because in a ventouse it says because the suctioning increases the risk of intracranial bleeding, the thing that you give magnesium sulfate for. And even if you give magnesium sulfate, there's still a risk of intracranial bleeding, so you don't do it in preterm labour. And the last one, if the baby's got like a coagulopathy or some bleeding disorder, which I'm not sure how you'd know about at that stage, but okay, so C-sections. There are different categories. I won't go through all this, but you'll have the slides. So the elective is category 4, and emergency, the most important emergency is category 1. The others kind of fill in between. So for elective C-sections, these are things like if the baby's breached, if the mother's had previous shoulder dystocia. I tried to like group them on similar things. If it's a multiple pregnancy, you offer a C-section. Someone will take it, some might not, but C-sections are generally considered safer. If the mother's diabetic, because they're at risk of having big babies and therefore at risk of shoulder dystocia. If they've got placenta praevia or intrauterine growth restriction. If they've had a previous C-section, if the mother wants one, and then if they've got infection. So HIV infection with a detectable viral load, you'll do a C-section. And if they have active primary herpes simplex virus in the 3rd trimester because they're at risk of passing on to the baby and they haven't given the baby antibodies yet, so the baby can get some like systemic herpes all over and they can get like encephalitis and it's quite dangerous. And then emergencies are like obstructed labour, failure to progress, the baby's in the wrong position, there's distress, there's placental abruption, cord prolapse. We'll cover some of these next week, or not next week, next time I do a lecture. If they've got antepartum haemorrhage, you might do it. So lots of these scenarios, as I said here, you do a C-section, and it will normally be an emergency. Or if they've got preeclampsia, you do a C-section, or if they've got eclampsia itself. So there are 2 different types. There is the low transverse type and the classical type. So the low transverse is the most common method used. It uses a Fallon steel incision, and you can have like 1 or 2 if you've had 1 or 2 of these, but usually if you've had 2, they're unlikely to let you do a vaginal delivery, but if you've had 1, you can still try for a VBAC, so a vaginal delivery after C-section. And then classical, which is the straight line, are rarely done now. They used to be much more common methods, but now that medicine has evolved, they're not used. But they are done in some situations. So if the baby's really premature, if they've got congenital abnormalities, so for example, if the baby's got like I can't remember what I was thinking of, spina bifida, you might do a classical incision because it's easier to like take the baby out that way rather than if you do a lower transverse one. Normally the baby's head just comes out first and obviously you're at risk of damaging, they've got things sticking out the spine, damaging it, whereas if you do a classical incision, it's easier to like take the whole baby out. And you've got massive fibroids in the lower segment because it means if you do the lower transverse one, you still can't get the baby out. And if they've got a transverse lie, then it's easier to take it out that way. And then C-section deliveries are needed in the future. So if you've had a classical incision, you have to have a future C-section because the risk of uterine rupture is really high. Okay, I think that is everything. Has anyone got any questions? I'm sorry, the last bit on mode of delivery was a bit of a whistle-stop tour, but hopefully it covered like the main bits that you guys